Good morning and welcome to day two of Stroudwater Associates' sixth annual Critical Access Hospital Conference. Whether you've been with us since day one yesterday or are joining us for the first time today, we are grateful to have you with us. At Stroudwater Associates, we work exclusively with rural hospitals nationwide. Our team includes former rural hospital CEOs, financial leaders, clinicians, operators, and strategic advisors who understand firsthand the realities rural healthcare organizations are navigating today. Throughout this conference, rural healthcare leaders and industry experts are sharing practical strategies, lessons learned, and real world approaches that hospitals are actively implementing to strengthen operations, improve sustainability, and better support the communities they serve. Today's session will focus on service line growth, swing bed strategy, and expanding specialty care access through rural health clinics, all areas where thoughtful planning, operational alignment, and financial discipline are becoming increasingly important for rural hospitals. We are excited that you have joined us today for this first session. I should be being joined by Wade Gallen and Cameron Smith. They will be talking about service line development best practices, grounding growth in financial and operational realities. As I shared, our speakers are Wade Gallen and Cameron Smith. We will begin day two with a focus session on one of the most important and often challenging strategic questions rural hospitals face: where and how to grow. Adding a new service line can strengthen access, improve financial performance, and better serve community needs, but only when growth opportunities are grounded in operational realities and disciplined analysis. In this session, Wade and Cameron, senior consultants at Stroudwater Associates, will share practical frameworks for evaluating service line opportunities, assessing operational readiness, and avoiding some of the most common pitfalls organizations encounter when pursuing expansion strategies. Drawing from experience working alongside rural hospitals on financial, operational, and performance improvement initiatives, Wade and Cam will explore how hospitals can better align leadership teams, operational teams, and financial planning around sustainable growth decisions. Carry on, gentlemen.
Thank you, Amy. It is a pleasure to be here with you all this morning. Thank you for joining us for day two of our conference. Myself and Cameron are excited to share this topic with you all. This is one, just for context, has been a focal point for many of the rural hospitals that we've worked with recently. Really, this desire to make sure that the service lines that we're offering as a rural hospital are grounded in financial and operational realities. This could mean a whole host of things, including whether we start a new service line. It could be evaluating existing service lines and the sustainability of those, as well as growing and potentially expanding service lines that we've already developed as an organization. So we're really excited to jump into this topic with you all. And again, good morning to everybody on the call. We'd like to start by sharing some of the high-level learning objectives that we have for this session. The first one is really understanding those key data elements that are required for an effective pro forma or analysis of your service line. Understanding how those data elements really impact each other. So it's not always a 1 + 1 = 2 scenario, as we'll talk about in a little bit here. There are nuances that we need to be aware of, and there's an interaction that happens between our service lines in many cases. Determining what some of the assumptions need to be when we're thinking about something like developing a pro forma or evaluating our existing service lines is hugely important. There are a number of assumptions that go into these types of analyses, and we need to be aware of those. Identifying key stakeholders is a huge area as well. When we're working on developing potentially a new service line or evaluating existing service lines, we can't do that in a bubble. We need to really include some of the key stakeholders in those decisions and even the analysis that goes into evaluating these service lines. Developing an effective communication process. What does that look like exactly? and then identifying some of the common pitfalls that we see when we work with rural hospitals who are thinking about some sort of pro forma and analysis of bringing on a service line, evaluating existing service lines. There are a number of pitfalls that we see, and so we're going to share some of those with you all today and talk about those. And to start, we really want to focus on some of the fundamentals around rural hospital economics as we see it here at Stroudwater, because I think they set a really good stage for analysis around service line development. But to kick this off, we're actually going to start with a polling question. So, does your organization have a system in place to evaluate a potential service line? So, you're thinking about potentially bringing on a new service line. Do you have a system in place to help you evaluate what that service line looks like? What's the feasibility of that service line? And whether or not it makes sense to proceed with offering that service. We'll give a quick minute here for that polling question to come through.
It's going to say, yes, Wade, that polling question has come up and is shared.
Perfect. Thank you, Amy. All right, what are the results looking like? We are, okay, starting to see. Okay, so based on the poll results, we're split almost half and half between yes and somewhat, or at least those are the two leaders. A number of organizations, so 13% reported that no, we do not have a system in place to evaluate these service lines. And then roughly 12% noted that they were unsure about whether or not there was a system in place to evaluate a potential service line. So this is really helpful. What I'm gathering from this is over 30% of organizations on this call at least feel like they do have a good process in place, which is an excellent place to be as an organization. And hopefully what you'll find valuable in this session is really validating some of the processes that you already have in place. And then for the others who are joining who might not have a process or at least are they have somewhat of a process, but are looking to refine it. I'm hoping that this session really helps you all think about ways to do that. So again, starting with some of the fundamental economics for rural hospitals, we want to start by defining contribution margin versus profit on fully allocated costs. So this is really important when we're evaluating service lines because we want to understand especially what is considered variable cost and fixed/step fixed costs. So variable costs, those are expenses that change based upon changes in activity and remain the same on a per unit basis. So taking us back to kind of accounting 101 or economic 101, we are looking at the per unit cost that doesn't change necessarily depending upon the number of units of service we're offering. And then we have fixed costs. So some examples of variable costs that we typically see include pharmaceuticals, reagents, food in many cases. And then we go into the fixed and step fixed cost component of this, which are expenses that won't change depending upon changes in activity. So if we offer more units of service, that isn't going to change our fixed cost structure. There are step fixed costs, and this is where some of the nuance lies in our analysis from a service line perspective. These step fixed costs are costs that will change on an incremental basis, but only once you hit a certain threshold from a volume perspective. So if you're offering X number of units of service, once you hit Y units of service, that's going to result in additional staff, perhaps, that's required to cover that service that you're planning. And so that would be a step fixed cost. It's not going to go up based upon the number of units until you hit a certain threshold, and then you will have to increase those costs. Some examples of this, a really big one is salaries and benefits. You would make the argument that this is more of a step fixed cost. In many of the cases with the organizations we work with, that's more of a fixed cost. So there are some step fixed components to it, but we're thinking mostly of that fixed cost component. We also have things like rent and utilities that aren't necessarily going to change. You could make an argument that they're step fixed if we have, say, a renovation that we're doing, or if we rent out a new facility to offer this service line. But generally speaking, these are fixed costs that we need to consider. And why this is important in the context of service line analyses is that we want to make sure we really understand what the true contribution margin is from a given service line. We have a very high amount of fixed costs as a rural hospital. And so understanding what the true contribution margin is, we take out some of that fixed cost from the equation, and we don't always rely on fully allocated costs, which includes all of the overhead associated with running our hospital. We want to really be thinking about that and using that as a key component to any analysis we're doing from a service line perspective. Just to reiterate this, in our experience and outside of our experience, there's actually a lot of documentation around this. Rural hospitals have an inordinately high fixed cost structure, and this is even compared to urban counterparts. An example of this, there was a study published back in June of 2025 by RUPRI, the Rural Policy Research Institute. And this study, one of the things that was indicated in the study is that the ratio of fixed cost to total cost actually went up depending upon the rural nature of the organization. And so the more rural you get, the higher the level of fixed costs in comparison with the total costs. And so for our rural hospitals, a lot of our costs are fixed. We have things like emergency room standby, which we need to offer. We have acute care nursing costs, and just because we don't have a patient that presents in the emergency room or we don't have someone on our floor at the moment, that doesn't necessarily mean that those costs go away. And so when we're thinking about this idea of contribution margin, what we're thinking about is the amount of each unit of service available to cover fixed costs and provide profits. So if we have a price for a particular unit of service, let's say it's $200, the true variable cost associated with that is typically quite low. In this case, we're assuming $30. That means a unit contribution margin is $170, and that can be used to offset many of the fixed costs that we have as an organization. So we like to think about it and frame it that rural hospitals are made up of thousands of unit contribution margins. And when you begin to approach performance improvement in this light, it becomes very clear that if we can grow services, that can actually help offset a lot of the fixed costs that exist within our organization. And then for our critical access hospitals that are on the line today, we also want to recognize that our price that we're using for determining contribution margin isn't necessarily always a fixed number, right? We're dealing with cost-based reimbursement from at least a traditional Medicare perspective. And so our per unit service price will actually change depending upon volumes, assuming our cost structure remains consistent. And so that is a component of the equation. It's not the only part of the equation, but it is a nuance that critical access hospitals have to evaluate. And again, just an overview of cost-based reimbursement. Really, this is provided for Medicare, so traditional Medicare, and in some states, Medicaid also follows cost-based reimbursement for critical access hospitals. And so what does it do? It partially insulates hospitals from the financial impacts of significantly low volumes. Again, our rural hospitals are seeing lower volumes, usually substantially lower volumes than many of their urban counterparts. And so the cost-based reimbursement mechanism is designed to help in those situations to allow for sustainability even when we don't have the volumes if we were paid on a straight fee-for-service or PPS type basis, prospective payment system basis. And so it does not, and I want to stress this, it does not protect us from all financial woes, and it doesn't negate the need for us to have prudent cost management strategies, but it is a nuance that needs to be considered in the context of service line development. And then the Medicare cost report, incredibly important as we think about our service line pro formas analyses. We have to incorporate the Medicare cost report into those decisions. And with that, I'm going to turn it over to Cameron and have him talk a little bit more about the elements of a pro forma. What are we needing to get that done?
Yeah, thanks, Wade. So we're actually going to kick off, I believe, with a polling question here on the next slide when we think about what does it look like for us to develop this pro forma. So the question we have for you all is how confident are you in your organization's ability to understand market demand before launching a new service line? We're still getting some respondents. All right, we're going to go ahead and end the poll. I think we've got a decent amount of people who've responded. So what we see, and this is great information to have, is very few people, only 2%, showing not confident at all, and very few, only 25%, either not confident at all or not very confident, with most people, over 50%, either being somewhat confident or very confident in their ability to understand market demand before launching a new service line, which is great. One of the things that we're really going to dive into in the next couple of slides is what does it look like to define that service area, and what are the key considerations that we need to have as an organization to figure out if the juice is really worth the squeeze to develop this new service line and what that entails. So great to see that almost everybody here is confident or very confident. Hopefully this continues to affirm that thought. Let's take that down. So when the goal of developing a pro forma, before we even go into the process, is to begin with the end in mind. What are we trying to solve for? What is the purpose of developing this pro forma? Why are we thinking about this potential service line? Is there a reason that we're looking to start this? Does it align with our organizational goals, our organizational strategic plan? Did it come up in a community health needs assessment and it's something that we're reviewing? Is it something that community members have asked for, the board's asked for? Is it something that we've thought about as a senior leadership team and have determined that regardless of necessarily our access to care, it's something that we should have in our community and we need it because of geographic isolation? So think about all the reasons that we would look at a service line and figure out what am I trying to solve for? What is the end goal of this? And then what's the time horizon? How far out is this? Is this a 6 month, 1 year, 2 year type endeavor? Because that really helps understand which way is the market moving and how much time do I have before I want this service to be offered. And equally as important, what is the current financial position of the organization? Is this going to put us in a position where we have to spend cash to start this service line? Is there going to be enough contribution margin from the service line to make it worth the squeeze? Or is this something we're doing ultimately for community benefit? And then finally, what's happening in the market, both locally, nationally, even in the state level? What's going on? Are there market disruptors such as Amazon or other players that have entered the market and are disrupting the area that are requiring us to start this new service line? Is there an opportunity because somebody left the market and now we can enter that market with a new service? So all of those key considerations before we start developing this pro forma are going to help craft the overall final result of what that looks like. So when we think about on the next slide, what that end in mind looks like, a couple key things to think about for the overall pro forma. What is our market? Very often, hospitals will start this process of developing a pro forma or wanting to start a service line without actually understanding the amount of services for that particular service within the market. What is the utilization of that service? Is there enough, if we're going to start an MRI service, is there even enough MRI services available within the market to make it worth putting in an MRI machine? So crucially, it is important to begin with an understanding of the market. What does it look like from a geographic perspective? Is this something where we're putting this in because we have geographic isolation and people have to cross a mountain pass to get this service otherwise? But once we know our market, the players in our market, that really helps shape the idea of what does this look like moving forward for us. So defining our service area. What are the zip codes that we're serving? How far and broad is this? What does this service area look like? Services offered in Kansas where people have, relatively easy access to get on an interstate and drive is going to look different than, a mountainous area such as Idaho or Colorado where people in different seasons have to take very different routes to get access to care. So what does that service area look like? What are the geographic conditions of that service area? And then what are the demographics of the service area? Very often in our rural markets, we're seeing an aging population in our service area. What is the median household income of the service area? Can people easily access transportation to get to our organization to receive the care they need? And then start to evaluate trends in utilization for the service area. At what rate are people utilizing our services? Have we determined that there is enough within this market and we have enough market capture to start a new service line effectively? Doing that through utilization of historical volumes. what is our current capture rate if we develop a theoretical market share? Do we have 85% ED market share and 85 CT scan rates? So we know that we're getting a decent amount of people from within our service area or what we define as our service area to come to us. Or are we looking to broaden our service area? Are we looking to start something in an area adjacent to us that we've never looked at before? And what would utilization look like there? And then finally, estimating those future volume changes. Do we anticipate volumes in our service area going up or down? Is the population increasing? Is it decreasing? And then on a service line basis, on an offering basis, do we anticipate services to increase or decrease over time for the new service that we're looking to offer? Which should help answer the key questions of, is there enough volume to justify this desired service? Are we looking to grow? And then finally, how much do we think we can capture? Are we looking to get 5% market share, 20% market share? Are we not concerned about market share, but we think this is just something that the community needs? And when we think about beginning with the end in mind and defining that opportunity for market demand, there's really four levers that we look at to define market demand. The population times utilization rate times market share and times throughput. Population being the geography, the total market, aging, gender, the special populations we have to consider. What is available in my service area and how can I get access to it? Utilization rate, at what rate are people going to utilize my services? Should I offer them? And then the market share. Is there competition? Are there other people within the service area that insurance companies may steer up organizations to? Freestanding imaging centers, urgent care. What does the competition look like? Do I have primary care alignment and organizational alignment? Do I need to access a specialist to grow market share for this new service? And then finally, throughput is the most controllable on our end. At what rate can I move people through this system to grow volume? Do we have open access to care if we're going to start this? Or is this only going to be offered 1 day a week, 2 days a week? At what access is the community going to have to this new service? So when we put that all within our operating parameters and think about these four levers, that helps define how much is there to really begin this service. Once we've defined that service area, it really then becomes collecting the data for the pro forma. That means, do we have a financial model developed? I believe the earlier polling question that Wade asked, most of us feel like we have somewhat of a process to develop a pro forma. So what does that look like? Do we understand it? And then can we roll out variable scenario analysis? Do we think we're going to get 5% plus market share year over year? Are we going to grow this service? Modeling out various scenarios helps understand if this doesn't go the way that we necessarily planned it to go, is there still going to be enough benefit for us, whether it's in the community or for the organization, to launch this service line? Most often, it's a 3 scenario analysis of best case, worst case, and something in the middle around reality. And once we understand that, what are the conclusions that we can build upon from those stated goals? So if we begin with the end in mind, we've collected our necessary data and we've got a financial model and some scenario analysis. Do those scenarios line up with what we started with? Do they match the goal that we had when we initially set out to do this pro forma? Next slide, Wade. Some of those key data elements that we're going to want to look at, as we said, internal volume statistics. How do these compare overall to what we're getting in the market? And what does market share look like? Do we have the volume statistics to back it up from our EHR? Do we have access to our financial statements? As Wade mentioned, the Medicare cost report. I see a hand raised. Do we have the FTEs to grow this service line? Very often, when we think about step fixed and step fixed costs, there's likely going to be an FTE investment involved in starting some kind of new service or growing that service. And then understanding our payer mix or our reimbursement rates. Are we getting paid on a fee schedule, DRG, or percent of charge type model? I don't know, Wade, if you want to expand on the reimbursement rates or the current payer mix conversation at all.
Yeah, no, I would just add that they're very important considerations when we're looking at the financial feasibility of starting a new service line. And our key components we need to estimate and make sure we have data to support whatever we're estimating for those. And I would also just add a note on the internal volume statistics, because sometimes we're in situations where we're evaluating a brand new service line that we don't really have those historical data points that we might like to put together something. And so in those cases, we really need to sharpen our pencil and make some assumptions around what those volumes might look like for a brand new service line where we don't have much in the way of historical data to back that up. And so there are ways you can go about that. And so it's just a really important nuance there that it depends on whether we're looking at an existing service line or whether we're looking at a brand new service line that is not really related to some of the services we currently offer as an organization. So a key nuance there.
Thanks for the clarification there, Wade. Good call out.
Yeah, absolutely.
When we think about who's going to be involved in some of the key assumptions, once again, as Wade mentioned, what does future volume growth look like? What is our gross charge per service per unit of this service, the payer mix for the specific service line, and then what's the expense growth specific to this proposed service line are all key assumptions that we want to look into as we build this out, understanding that it's going to be nuanced. There's going to be different reimbursement models for various service lines, and how does this impact, cost-based reimbursement on the Medicare cost report and our overall ability to kind of make revenue from this service. So when we kind of answer those key assumptions, we can then build out and develop that pro forma effectively and understand those various scenarios.
Absolutely. And just to add on to that, this is what brings us back to the initial conversation around contribution margin and what represents fixed versus variable cost. Even when we talk about expense growth for a specific service line, it's important to understand what the fixed costs are associated with that. So let's say we're starting a new service line. What is the minimum kind of dollar amount that we're going to need to expend above and beyond but what we currently are in order to make this feasible? Or are there opportunities to leverage existing staff to be able to service this new area that we're thinking about? So it really comes back to that conversation around what the fixed costs and the variable cost structure is for our organization and having that true sense of contribution margin.
Slide, please. And who do we want to involve? CEO, CFO, providers. I really want to kind of focus on providers here for a moment. What degree of support do we have from the providers? What level of alignment do we have? And is this a service line that's going to require bringing in specialists? Is it going to require access to telehealth or services that we otherwise haven't considered as an organization? It's crucial to make sure that we have providers at the table as partners, not necessarily just a group of folks that we're informing we're starting this service. We'd love you to refer to it, but making sure that we're bringing them to the table as partners, they're evaluating the need there. And then also the department managers and the revenue cycle team. Department managers from the sense of if our community understands and our employees and our department managers kind of being that front line of marketing for us, if they understand these new services, they're going to be able to promote them. They're going to be able to speak to them. If it's an expansion of a service line, they can speak to the operational challenges of what it's going to take to get us from 25 or 30% market share to 50% market share. And then also involving the revenue cycle team to make sure that we're effectively billing and collecting for these services that we're starting and that it's going to be documented correctly. The last thing we want to do is start something brand new and then not get paid for it, or expand something and not get paid for it. So when we think about the key stakeholders, there's probably many more people that need to be involved in the development of our pro forma than just this list here. But these are definitely the bare minimum stakeholders that we'd want to see involved in that process. And also, you look out to your community. What is the community saying? Do you have a patient family advisory council? What does your board say? What are you hearing within the community as well? Are you going to health fairs or community organizations and you're hearing that there are key services that need to be started within the organization? And taking that into consideration. Again, the CHNA is another great way to inform what this looks like. It's not the only way to inform organizational strategy around pro formas and service line development, but are we looking at all of the people who potentially may have some kind of role in this service line and what their voice is? And then how do we communicate that effectively? Again, going back to what we just kind of went over, are we communicating these service line decisions to our payers? What do the contracts look like on that side so we can effectively get paid? Are we having communication with our providers so they understand why we're starting this service line? What is the reason behind it? And have they effectively had their input into this as well? again, department leaders for those operational decisions and so they can market it to the community. And again, informing the community, what does the marketing plan look like to develop a new service line or expand a service line? Is this just an under-marketed service that we want to grow and know that there's room to grow, but we haven't put ourselves in front of the community yet? So what can we do to get radio ads in front of the community or commercials? How can we put ourselves effectively in a position to market this service, whether it's expanding or starting a new service line, so that the community is aware of our services and what it looks like from a global scale? I would almost argue that this actual graphic should be changed so the arrow's pointing back as well, so that central communication team. But overall, do we have a communication strategy as our service line is developed? And is it one that everybody is aware of? The last thing we want to do is start a service line and somebody say, I wasn't aware we offered that service 5 years down the road.
Yeah, that's a great point, Cam. And I think when we're working with rural hospitals, that's a lot of what we hear is that whether it's the providers that don't have a good awareness of the services that are being offered in the local rural hospital, or even the community, there's oftentimes this gap in an understanding of what's offered versus the reality. And so I can't reiterate enough Cam's point to we need to be having effective communication with all of these groups, right? And vice versa. But we hear this time and time again. It's a common theme. And so it's incredibly important that we communicate that and also communicate the rationale behind it. I think another challenge that can be seen sometimes is, we've done the analysis, we've done a great job of understanding the financial side of this and the patient access side of it. But then communicating the rationale behind the decisions can also be a really important piece. So I appreciate that point. All right, so we're going to jump into some common pitfalls that we see here at Stroudwater when we're helping rural hospitals think through service line development. But we're going to kick it off with one more polling question in the section. So, what is the most common reason your organization considers adding a new service line? So again, what is the most common reason your organization considers adding a new service line? We'll give it a few seconds here for the poll to get enough respondents. Okay, we'll just give it a few more seconds here. Some themes are definitely emerging. Okay. All right, we'll end the poll here. And what we're seeing is that over 50% of the organizations participating here have the most common reason being a community need. So that's the most common reason that we're adding a new service line. The next most common reason is the financial opportunity, and that roughly 33% of respondents noted that, and then competitive pressure, physician and provider interest, and donor or external funding were on the lower end for those organizations participating here. And so what I'm kind of interpreting from this is that we, as is very true in most cases, we have a strong handle on the community desires for services and the needs within our community, and how we can rise to the occasion of meeting those needs through service line development and even offering new service lines for our communities. So this is excellent. Some of the pitfalls here, and we'll kind of each share our perspectives on some of these, but really putting the cart before the horse. I think Cameron spoke to this very well in talking about the market and what the actual need is. So when we're putting the cart before the horse, what we're meaning by that is we jump into something that we haven't done our due diligence around. And so that is a common pitfall that we see. Misunderstanding that true variable cost can oftentimes be a pitfall. And I would argue that that's not only a pitfall when we're thinking about new service lines, but evaluating the financial sustainability of service lines that we may have right now. I think when we don't understand that variable cost and we put too much emphasis onto areas of our organization that are fixed in terms of the cost, we can make decisions around whether or not to continue to support a service line that might not be aligned with reality. And that can be harmful to the community as well as our organization. So, really having that strong understanding of the variable cost. And then making assumptions that aren't really based in reality. I know Cameron talked about the need for when we're putting together a pro forma, particularly around new service lines, the need to have some sensitivity analysis that goes along with it, right? We want the ideal situation to be the case for our organization, but too often we find that that's not the case. And sometimes we can be overambitious, especially if there are advocates of a particular service line within our organization. They really want it to happen, but that can sometimes lead us to perhaps use overly optimistic assumptions in there. And Cameron, what would you add to this?
Yeah, I would that first pitfall of the cart before the horse. Have we looked at the market? One of the other things beyond just looking at the market is have we looked at the need for the providers? Do we understand, is this going to require a specialist that we don't currently have within our service area, within our community? And is there enough market to support a busy specialist, or do we need to look at telehealth? Very often organizations will start a service line and not look at their market or not understand their market and bring in a provider or a specialist with the idea that this is going to draw people from beyond the service area. But there just isn't enough volume necessarily, whether it's through lack of marketing or just lack of volume or other competition to sustain that specialist. So then we're in this constant churn of we're trying to recruit for this service line and it becomes an unsustainable model. Very often, when again, misunderstanding of true variable costs and making assumptions that aren't based in reality, one of the key questions to ask before we start this is, if yes, we have enough market, but is it a sustainable market and how are we going to sustain this going forward? It doesn't help us to create a new service line if every time we go to start a new service or a new offering, we have to slowly kind of backtrack and say the service is no longer offered here or it's being paused. And once we get this specialist or we get X, we'll look at reoffering this service. So what does a sustainment plan look like as well when we go into it? It's one thing to start a service line. It's another to make sure we understand going into it. What does it take to actually keep this going for the next 3, 4, 5 years out?
Yeah, great point. Great points. Another common pitfall that we see is this whole notion of garbage in, garbage out. And I'll speak from the, financial side, that being a big part of my background in helping evaluate service lines from that financial perspective. As we mentioned before, and as Cameron touched on, we need to have some sort of financial modeling for our service lines. We can't just go into them without a sense of how it's going to impact the organization financially, and we want to make sure it remains financially sustainable. And so there is a need to do some financial modeling around those services. However, we also need to evaluate the quality. It's not just having a financial model, but it's how accurate is that financial model, and does it account for all of the variables that need to be considered in that analysis, in addition to having the right assumptions, right? So, for example, are we going to be offering a service through perhaps we want to incorporate a new provider into our rural health clinic. Perhaps we are looking at operating a provider-based clinic. Maybe we are looking at a service line that has a very different rate of, say, traditional Medicare utilization than what we have historically, and we're a critical access hospital and need to account for what that might do to overall Medicare reimbursement. There are all these really strong nuances that are hospital dependent. And so we can't just have this global, all-encompassing model that accounts for all of those nuances. We have to make sure that what we're inputting into it is the right data. And also to the point around our starting data points, we need to make sure that those are accurate as well. Are our current financials accurate and up to date? Are they reflective of the most recent data that's available? These are all questions we need to add to make sure we don't fall into this pitfall here.
Another common pitfall when we think of the garbage in, garbage out data did we just go through an EHR conversion? Are we trying to make
Mm.
decisions with an EHR that we don't fully understand or are still trying to learn? That we've encountered quite a few instances where we've just went through an EHR conversion. We're looking to start this new service line, but we also don't fully trust that all of the data is effective or that we have everything lined up effectively. So, do we understand the system that we're working in currently as well?
Yeah, that's an excellent point. Some of the things that we hear when we work with rural hospitals who are considering a new service line of some kind is, well, we have a certain amount of dollars that have been allocated to this. Perhaps it's through a donor of some kind. And so we need to proceed with doing this service. There's this kind of notion that we have some financial backing. There's some skin in the game here from our community, or at least for a community member or some other donor. And so we should move forward with this. Another thing we hear is, our last CHNA, our health needs assessment, told us that the community wants this service, and so we need to do this. And I'll backtrack a little bit because we've been referencing the CHNA heavily and its importance in thinking through what the community need is, and we would argue that that's absolutely the case. However, we need to evaluate that as one part of the overall equation. Just because we had something that showed up on our CHNA doesn't necessarily mean that we need to do it. It just means that there has been a community need that's been communicated through that avenue. So I think it's an important input, but it shouldn't be the sole reason for pursuing something like that. At my last facility, we provided this service and it did really well. So we should do it here. Speaking to someone who has perhaps transitioned organizations recently, our biggest competitor recently started providing this service, and so we need to remain competitive in the area. We're going to lose market share if we don't offer this service because our competitor is. And then, hearing from someone else, perhaps that's, you've attended a recent conference and you've spoken with another hospital leader, hospital operator, and they've said that this service tends to be a moneymaker, and so you should consider doing it. Again, these are the things that we typically hear, and none of these things in and of themselves are perhaps inappropriate thoughts for service line development. But the key is, what do we do? These shouldn't serve as the sole rationale for why we implement a new service in our community. We would, again, call you back to it needs to be grounded in data, needs to be grounded in data around the market, data around your financial position, data around what can be anticipated in terms of volumes for this service, and really thinking through again that contribution margin. So we want to think of these, but also remember that we need to ground our decisions in data. Cameron, any thoughts?
Yeah, the other thing that I would add is we've talked a lot about what does it look like to start or expand service lines. Another pitfall that we often see is this service X doesn't make us any money, or we're losing
Mm.
X on this service without fully understanding how does that impact the entire organization. Does it impact, our DIS percentage, or does it impact something that's going to allow us access to some other benefit? So oftentimes we've made this decision because we don't think it makes us money without understanding the true contribution margin of that service line to the big picture.
Yeah, that's a fantastic point. And again, for our critical access hospitals that are on today, you add or remove it all. It isn't just that one service line that's impacted. It's your whole organization, and that's true for non-critical access hospitals as well. But you can feel it very acutely from a critical access hospital perspective in the form of your Medicare cost report and how it impacts that. And so, as we think about the realities. Again, can't reiterate enough that rural hospitals are all different. If you've seen one rural hospital, you've seen one rural hospital. The communities that we operate in as rural hospitals are very different from each other. What works in one location may not work in the other location. And any decision that we're making needs to be grounded in a deep understanding of our market, accurate data, financial data. It needs to be aligned with our organizational goals. We shouldn't be quick to jump at various offerings unless we have an alignment with our goals as an organization. And we also want to make sure that there's financial sustainability that is accompanied with any service line decision we would make. That's impacted by a variety of factors. And you really need to have something very concrete and tested to help you navigate what that financial sustainability is or is not when we're thinking about our service line development. And again, that works for whether we're thinking about a new service line or whether we have an existing service line and are evaluating its financial sustainability. We have to make sure we have something that is tested, that we know to be accurate to help us navigate that financial sustainability conversation accurately. And so really these are the realities we want to deal with. We want to leverage perhaps some other questions we have and some thoughts that we just talked about on the last slide, but those can't be the sole drivers. We need to make sure that there is enough data to support whatever decision we decide to make and that data is accurate and we're grounding it in reality. So Cameron, any other thoughts to add?
No, I think you summarized that really well. I did want to take a moment, though. I know that we did have one question kind of come through the chat that I just wanted to read off. I see Amy joined. I think she was going to read it, but I'll go ahead and just kind of throw that in there real quick, Amy, if you're okay with that, because I've got it in front of me.
Yeah, go right ahead, Kim.
So the question is, how can I get data and insight into the knowledge to bring on a new service? For example, I'm building out a pro forma for a surgery suite, but I know nothing about surgery. Any suggestions beyond paying a consultant?
That's a great question. Do you have any initial thoughts to it, Cameron, or I can jump in and share some thoughts?
You jump in. I will think about it now that I've read it.
Yeah. I mean, one of the biggest pieces of input I would have, so every hospital and every community is different. And so I'll say that till the cows come home. However, it might make sense to phone a friend who has implemented something similar to what you are implementing, and ideally at a local level, if possible. So, because some of the nuances in your state will be different. So even if you talk with another rural hospital that's in a different state, there might be reimbursement nuances that would impact the feasibility of that service in your area. But I would certainly phone a friend, if you operate within a network of any kind, a rural health network, that might be a good opportunity to reach out to peers. And then, you don't necessarily need to outsource the whole thing to a consultant, but sometimes it might be helpful just to get a second opinion. It doesn't have to be a full-on development of a feasible financial model, but it doesn't hurt to at least get a sense of how accurate is this based upon your experience with other rural hospitals. So I definitely say phone a friend first and see if you can find someone who has done what you are doing or attempting to do.
Yeah, I would agree with the phone a friend first, and then to whatever degree you can get access to data that shows the market for you all. What level of market data do you have to even understand? Is there opportunity available in my service area?
Mm-hmm. Yeah, different states will have different databases that might be helpful in your quest to understand what's available in the market. So some of these networks or databases can be accessed by you as an organization. And so it might be worth keying into who that organization is in your state and seeing if they have any data around this to get to that demand component as well, as Cameron just mentioned.
And then another question that came in, Wade, primarily, I'm going to center this one for you. Will you weigh in on services that are under consideration to be cut if revenue percentage is tied primarily to traditional Medicare?
Yeah, I would say tread carefully. We have seen many instances in which, and this is primarily for critical access hospitals, where I think that there can sometimes be a misunderstanding that there's this 1-to-1 ratio. So if you cut $1 of cost, that means you add $1 of margin to your organization. And in a critical access hospital, that's not the case generally, is you have a component of your revenue tied into your costs. And if you have a very, very high traditional Medicare payer mix, that certainly muddies the water. So it doesn't necessarily mean that if you're thinking about the sustainability of an existing service line, that you should factor in Medicare only, but it is an important nuance. And I would say that tread very carefully and make sure that whatever you're using to model the financial impacts has a really good handle on the Medicare cost report and how that decision will impact the Medicare cost report. So that's what I would say to that question.
All right. How do you factor in future shifts to value-based care, which is gaining momentum in critical access hospitals?
It's a good question. It's a good question. Well, I'll share from my perspective, and Cameron, feel free to jump in. We see a huge emphasis in the future. There already is a huge emphasis on it, I would argue, but an even greater emphasis on the role of primary care in those value-based care models that can sometimes have attribution associated with it. And so this push towards value-based care, I think, heavily impacts how we should view primary care and the access to care within our community. So if we have a strong primary care footprint in our community, that gives us the opportunity to leverage that and potentially do better under a value-based care payment environment, because we're not going to be as tied to this traditional fee-for-service environment where, you provide X procedure, you get this amount of revenue, and, it is what it is. It's going to be focused on how are we caring for the patients in our community. And a lot of that, at least in our experience, is tied to the primary care footprint that we have in our community, and how aligned are we with that primary care as well.
Yeah. One of the common questions that we'll ask is, are we understanding where our referral patterns are coming from, and are we tracking referrals? And we should be seeing a good chunk of our referrals coming from our primary care providers. So to Wade's point, are we fundamentally aligned with the primary care providers in our service area?
And there is another question on, do you have a best practice recommendation about how to do a look back analysis to compare reality to what was projected in the new service line after it was approved?
That's a good question. So I can't say that there's one methodology that I'm at least aware of that is a tried and true methodology to get to that point. There is sometimes a challenge with breaking out financials at the service line level. It's not always easy to do. And particularly, I'm thinking about things like our contractual allowances, which are notoriously difficult on a service line basis. However, we can certainly look at things like the number of units associated with that service line. Looking back, once we have some time behind us, seeing if the volumes that we are actually seeing were in line with what we had projected originally, which would tie into our gross revenue targets. Expenses, we're able to, typically the organizations we work with have a pretty good handle on their expense structure. And so, I would certainly recommend looking back at the financials, both at the service line level, but also at a global level, pre and post service line implementation, and seeing if, again, what we modeled out is actually coming to fruition, because that might signal, and not coming to any conclusions until you've done the full analysis, right? Because just because we haven't been recognizing, let's say we're looking at contribution margin, we may have not hit the margins we were expecting to based upon our pro forma that we put together. But what does that signal? Does that signal that it's an issue with the service line itself, or is there some other operational challenge that's preventing us from obtaining what we had projected to obtain? So is there an issue? Maybe it's in our billing and rev cycle that we need to consider. Has staffing been an extreme challenge, and so we haven't been able to staff up effectively enough to even achieve the volumes we were anticipating we would achieve. So there are a whole bunch of factors. So I would say, again, measure multiple times before you cut anything and have a true understanding of why we're not achieving what we had projected, and whether there's opportunity for us as an organization to move the needle. There are many things that are under our control and a number of things that aren't, but focusing in on what can we control.
I would say at a minimum, just make sure you're getting paid for the services that you
Yeah.
projected. So I do know that we do have some unanswered questions and we are coming upon time. If you do have any other questions, feel free to put them into the Q&A and we will get those answered. There was one final question or one other question that came through that asked, who can we contact? And I would say, here is Wade and Cam's information for you. It's listed on the screen. Feel free to reach out to them directly. They're always willing to answer any questions that you may have, and you can reach out to them about that. And again, if you send it through the Q&A box, we will make sure that we get those answered and returned to everyone. So with that, I just want to say thank you very much, Wade and Cam, for an insightful discussion around balancing these growth opportunities with financial and operational realities. If to the audience, if you'll be joining us for the next session, we'll begin at the top of the hour. To join, please return to the conference lobby and select the next session from the agenda. As a reminder, when you exit today's session, you'll receive a brief survey pop-up, and we'd greatly appreciate your feedback. It should take less than a minute to complete and help us continue improving our conference programming each year. Our next session explores how one hospital approached swing bed development as both an operational and community care strategy. So we look forward to seeing you over there, and thank you for your time today.
Thank
Thank
you.
you all.